So when we talk first about acute gastritis and Menetrier disease, I want you to think about it as a problem of imbalance, okay? This is from one of our anatomy sections on the gastric pits. And you remember that our mucous neck cells and our surface mucous cells can produce mucus and bicarb, okay? That's going to be important because that's going to be one of the biggest defenses to neutralizing some of the acid that's produced in our stomach. So if we have our gastric pit here, that's going to be producing acid, and we have to find a way to neutralize that sometimes. Otherwise, that acid can eat away through our own cells. And so we have a few defenses against that. We have our mucus and bicarb that I was just talking about. We also have, if you have a constant blood supply, that helps because you can actually neutralize the acid by washing it away within the blood or neutralizing it with products from the blood. And certain prostaglandins can also help to neutralize the acid, okay? So when you think about acute gastritis and Menetrier disease, I just want you to think about that balance. On one side of the scale, we have our acid, and on the other side, we have all these defenses. And if the side tips to where you have too much acid and not enough defense, you're going to get acute gastritis. And you can remember that by more acid equals acute gastritis. So the AC is going to help you remember. On the other hand, if you have this setup where you have too little acid and too much mucus, you can get something called Menetrier disease. And again, the M in mucus can remind you of Menetrier disease. I'm going to start with Menetrier disease because I think it's a little easier to talk about. So what happens in Menetrier disease is that your surface mucus and mucus neck cells get really, really big. They just start overproducing stuff. And because their job is to produce mucus and bicarb, they're obviously going to produce excess mucus. What this will do is it'll actually cause your parietal cells to die and you'll start losing protein. So let's go over each of those things and why that happens. So the first thing is you get hyperplasia of all of our mucus neck cells and our surface mucus cells. And obviously these produce mucus, so if they're bigger and they're more active, they're going to produce more mucus. And that's not too surprising. You can get parietal cell atrophy because especially these mucus neck cells, they can grow so big that they actually start pushing against or blocking the exit pathways for some of these parietal cells. So you can actually start killing some of the parietal cells in the process. And you get protein loss because remember that a lot of times proteins and water like to stick together. So if you're throwing out all this mucus, a lot of the proteins will get either trapped in that mucus and then they can't get absorbed because it's just a thick mucus layer. And so you'll actually lose protein over time. And so from this, you can get anorexia or weight loss because you can't absorb anything. You're throwing out all this mucus and it's preventing the adequate digestion of certain compounds. You can get vomiting and epigastric pain from all the mucus production. You can get edema and ascites. That occurs because you're losing so much protein. So normally protein can help you, like albumin, for example, that can help you keep your water within your intravascular space. You have a little bit of oncotic pressure bringing the water back into the space. The problem is if you just have very little protein compared to all this water, there's nothing that's actually helping the water gravitate and stay within the intravascular compartment. And so you're going to get water that leaks out, which will form edema or ascites. And on imaging studies, it's important to know that there's a characteristic stomach gyri that you'll see. And that's because the mucosal cells have just overgrown, and it looks like a brain. So here you can see on the left, it's just a normal stomach. It's very rounded. Everything's fine. And on the right, you can see it does kind of look like a mini brain inside your abdomen right here. And that's classic for Menetrier disease. So we've talked about what happens when we have too much mucus, but now let's talk about the other side of the coin. Acute gastritis, where you have excessive acid production and not enough of these defensive mechanisms. So acute gastritis is an imbalance in acid secretion, which will ultimately cause mucosal stomach damage. There's a few causes, and we'll go over each of these individually. You can get NSAID use, alcohol use, burns, increased intracranial pressure, shock, and chemotherapy. These are some of the more common causes of acute gastritis. So let's go over each of these in detail. We'll start with NSAID use. So kind of going back to a little bit of biochem, what's going to happen in pharmacology? What's going to happen is that we have phospholipids. They can actually be converted into arachidonic acid through an enzyme called phospholipase A2. From there, arachidonic acid can be converted into prostaglandins like PGE2. That's done through COX-1. Again, that's an enzyme. And this PGE2, this type of prostaglandin, can actually protect our gastric mucosa. So it's one of the defense mechanisms for acid secretion. The problem with persistent NSAID use is that NSAIDs are COX inhibitors. They can block COX-1, and by blocking this enzyme, you won't get any of your helpful prostaglandins, and you won't have the gastric protection. So you'll ultimately have too much acid, and that'll cause acute gastritis. Alcohol use is pretty straightforward. Alcohol can directly damage your mucosal cells through direct contact. So alcohol can irritate these. We know you need your mucus cells to produce mucus and bicarb. So if you don't have those, you get gastritis. Curling ulcers, these are caused by severe burns. And so what happens here is that you have a severe burn. That burn, if you've ever seen somebody in a burn unit, they're losing a lot of fluids through that burn. It's very easy to lose fluids. Our skin is some of our most important protective barriers in our body. So they'll become hypovolemic, and they won't have a good blood supply anymore to our stomach. They kind of have to shunt it to more important organs. And because of that decreased blood supply, you'll get curling ulcers and acute gastritis. And a mnemonic that you'll commonly see in some of the review resources is that you can get burned by a curling iron. To remember, curling ulcers are associated with burns. Increased ICP can cause something called Cushing ulcers. So how this works is that increased intracranial pressure will overstimulate our vagus nerve. And remember, our vagus nerve was important. It had two different pathways. It had the M3 pathway and the GRP pathway to ultimately increase hydrogen ion secretion through that hydrogen potassium ATPase. So if you're overstimulating that vagus nerve, you can get a ton of acid production, and you'll get acid hypersecretion and acute gastritis. And a mnemonic you'll see, I think First Aid has it and a few others, is always cushion your brain, to remind you Cushing ulcers are associated with ICP or increased ICP. And here we go. Here's a Cushing ulcer. If you imagine your vagus nerve gets big, all these pathways can get huge. And in shock, you're going to have a low blood pressure. So that makes sense that you don't have good blood supply. And so that'll cause gastritis. And that's why if you've ever been to the ICU, you'll notice a lot of people in the ICU are placed on a PPI, and it's to protect these people from developing a lot of these stress ulcers. And then chemotherapy should make sense. It kills any rapidly dividing cell, including some of your mucosal cells, so that can cause gastritis as well. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.